We're at BC Mental Health and Substance Use Services, a program of British Columbia's Provincial Health Services Authority. While our services stretch across the province, our team is located on the unceded traditional lands of the Musqueam, Squamish, and Tsleil-Waututh peoples, who have cared for this land since time immemorial. At BCMHSUS, we provide healthcare services to people across British Columbia with complex needs, including severe and persistent mental health and substance use issues, forensic psychiatric services for people with mental health and substance use challenges who have been in conflict with the law, and comprehensive healthcare for people who are incarcerated in provincial correctional facilities. In addition to these clinical services, we also provide provincial leadership in health literacy, stigma reduction, research, and knowledge translation and exchange, which is where our team's work fits in. In this video poster, we will describe a pilot knowledge translation and exchange initiative called Evidence in Care. Evidence in Care brings together multiple sources of knowledge, including researchers, healthcare practitioners, and people with lived and living experience, to conduct rapid reviews. Findings from these rapid reviews are shared back into practice via a contextually tailored, actionable evidence brief.
So, in an effort to effectively move evidence into practice at BCMHSUS, the Evidence in Care, or EIC program, provides decision makers with relevant research to inform health system policies and practice in a timely way. The EIC program utilizes the expertise of researchers, healthcare decision makers, direct care providers, and persons with lived and living experience or patient family partners to conduct rapid reviews and tailored evidence syntheses to facilitate the uptake of best practices. The engagement of knowledge users throughout the EIC process ensures evidence is tailored to the needs of those most impacted by the results and more likely to result in practice change. To date, the EIC program has completed 2 requests. The first one being, what is the evidence on learning and practice competencies for a post-registration curriculum for nursing in a correctional health setting? And the second being, what are the best practices across the continuum of care to prevent or reduce drug toxicity events amongst individuals with a mental health disorder and or identified mental health concerns who use substances? Results from the EIC request will be used to inform provincial nursing curriculums as well as guidelines for effectively preventing toxic drug events in BC.
One of the findings that's come out of the toxic drug crisis is that half of the folks that have had a drug poisoning event also have a mental health diagnosis. So that's 50% of the population. And so while all of them are using substances and any policy directives or any care changes that have come through are dealing with substance use, I saw a bit of a gap in what does the clinical care mean for somebody who also has a mental health concern. So that was our intention, was to fill a little bit of a knowledge gap in that space. The impact of the information that came out of it was that it was, now we have sort of a solid list of what the evidence is saying. And we didn't have that before. So now we can sort of say, okay, what are the next steps? Now that we've got it backed up with the research, and we validated it with care providers and decision makers and family members and peers, what do we do with it?
We talk about evidence and we talk about wanting to make decisions based on the best practices, best and current evidence, and developing wise practices throughout our journey in developing Indigenous culturally safe programming, in developing nursing practice and allied health practice. However, the benefit of having an evidence and care program allows us to have others do a deeper dive and bring that evidence forward. And sometimes we just don't have the time or the expertise to really do that literature review, that search, and that critical analysis of what the evidence is. It really allows for more innovation, more creativity, just additional thought on the possibilities of what we may be able to do.
We need evidence to mobilize change, and having multiple sources of knowledge, including people with lived and living experience, can help build the case for systems change. Working on the Evidence and Care project has been really enlightening to bring together all of the evidence that is out there and to really look and see what isn't being looked at. And I think myself and my lived experience colleagues have pointed out a number of things that are missing from the literature. And my hope is that the gaps and barriers that we have pointed out will be looked at.
Thing that is important in acknowledging what is known and what is not known. And we think we have evidence around specific areas or specific issues, concerns, and then discover that we actually don't. We think we know, but we're nowhere near what we should know. When we take this gap and we learn from it, then we can find out more. But we also discover what is working for a particular audience but hasn't been addressed by another audience. And I think it's really, really important for us to understand who the audience is and how they're applying their knowledge. And perhaps, and even desperately, they need to change, because if they don't change, lives are at stake.
I'm really hoping that the project will help push forward like policy changes that will enhance wraparound care for those facing like mental health, substance use, and most importantly, overdose, and maybe like create a more like effective response to the toxic drug poisonings that our communities are facing.
The research in this process, what we've done would be great for BC corrections. I think, times changed. Population has changed who is being incarcerated. And I think, from them seeing the gaps, because mental health and addiction is one of their top priorities. And I think without having the resources and the way to fulfill their mandate of what they're supposed to be doing, they can fight for better funding, better training if they did this process.
Advice to other organizations who may want to embark on this journey known as evidence in care: take some time to decide who your partners are, involve them at the beginning, create those terms of reference, ensure that everybody's on board and you have budgeted your time accordingly, and ensure that everybody knows their roles. Be prepared for the unknowns. You're going to start with a hypothesis and it may be upended. You may be completely wrong, or you may be completely right, and you may have to chase down the further pieces of that are going to have you engage appropriately with those afterwards who need to use and adapt to what you have learned. One thing that I would like to add is that we collect all the quantitative data in the world. If we don't add the people with lived and living experience to that, we don't actually then color the data. The evidence is no longer relatable.
As mentioned, our evidence and care team has successfully implemented 2 evidence and care requests. An evaluation of the program has been conducted to identify barriers and facilitators to implementation and explore future sustainability of the program. In general, an evidence and care request takes about 3 months to complete, depending on the complexity of the research question, and up to $4,000 to cover the cost of software, staff, and patient partner time. Given the potential for impact in closing the knowledge to practice gap, we believe evidence and care is an essential resource for healthcare organizations. To learn more, reach out to our team at bcmhsus_ke@phsa.ca. Thanks so much for listening.